some hopefully some will be able to join the meeting as we go along. Because of that, we cannot approve the minutes at this time. Perhaps if people join in later, then Teresa, just let me know when we get to a quorum, if we do.
Okay.
Chair Parton,
Yes.
this is Barry Martin. I didn't hear my name called, just FYI.
Okay. Teresa, did you get that?
Whose name was that?
Barry?
Barry Martin. I'm with Primary Care TAC.
I don't have his name on the active membership. I'm sorry.
There were new members added as of July, Teresa, and Barry was one of those.
Okay, Charlie, I went on the website this morning and printed out the active members list. Has it not been updated then?
I thought it had been, so I'll have to make sure.
Okay, because Dr. Parton, I might have the wrong list. I printed it out just about 15-20 minutes ago, so I might not have the updated list.
Barry, are you a member of the MAC or the TAC?
But
No, I'm a member of both.
All right, thank you.
Charlie, did you get me? This is Kathy Hannah. I couldn't find the unmute button at the time.
Dr. Parton, do I need to redo the list again then? Barry, which MAC are you with? Which one, so I can write your name on the list?
With Primary Care. And if you'll look at the roll call from last time, I was on there. I'm sure the website has not been updated.
Okay, I'm very sorry. So I've got you.
Oh, that's okay. I just wanted to make sure, just in case it changes the quorum, or if anybody else has not been on there.
Right. Teresa, go ahead and do the roll call again.
Can you all hear me okay? Am I talking loud enough?
I can
Yes.
hear you
I can hear you.
Okay. All right, so I have Dr. Parton,
here.
Nina Eisner, Susan Stewart,
Here.
Brian Proctor, Peggy Roark, Sheila Coran, and then I have two vacants on my list. And I have Dr. Jerry Roberts,
I'm here.
Eric Wright, Dr. Bobrowski, Dr. Compton, Dr. Mueller, Dr. Gupta, John Dadds, Dr. Hannah,
Here.
and Ann Morgan. Are there any MAC members that I did not call that are present?
Other
Besides
than myself.
Barry Martin, I should say that again. I'm sorry, Mr. Martin. Barry,
That's okay.
I still just have 6 out of 16, so no quorum as of now.
Okay, thank you, Teresa.
Uh-huh.
Okay, so again, we will not be able to approve the minutes at this time. Maybe later in the meeting, we'll be able to do that. Before we move into old business, I would like to let you all know that this will be the last meeting that we have with Charlie. She's retiring on the 28th of February. And I would like to send a special thanks to Charlie for all of your hard work over the years. You've been wonderful to work with, and everything you've done for the MAC and for the tax is so much appreciated. So if we were in person, I would give you a round of applause, but since we're not, just know that you are appreciated and you will be missed.
thank you, Beth. I appreciate that. I've certainly enjoyed working with the tax and the MACs. I've learned a lot through you all. For those of you that are in healthcare, I've always had a great deal of respect for you. But in the last 2 years, that respect has grown with COVID, and I wish you all continued success with not only the MAC and tax, but with your respective careers and so forth, enjoy them. And thanks for everything you all do for your patients and for our Medicaid recipients. You all are very much appreciated as well.
Thank you, Charlie. And you have a wonderful time on Route 66.
I hope to get there about the end of September.
Okay. Okay. So moving on then to old business. First up is again the question about Medicaid reimbursing certified professional midwives or CPMs. Where are we on that?
Hi, good morning. This is Veronica Cecil, Senior Deputy Commissioner for Medicaid. It is still on the list to consider as part of the overall maternal health, child and maternal health review that we're doing. Again, we're wanting to be very comprehensive in how we move forward. And this is just incorporated into that, reviewing how best to what are the best practices and what does Medicaid need to do to improve maternal health. So it's kind of captured in that. So we would not be moving forward on it until we complete that review, which, as you know, I think Dr. Terrio is planning to give an update at the May meeting on where we are.
Okay, that was my next question. Where are we with that? So, okay, so I will keep that on the agenda and we'll be asking about it again at the next meeting.
Okay. Well, again, certainly welcome to do that, but it is part of the overall maternal health initiative. So we don't consider it separate from that. It will be incorporated into whatever we do as part of that initiative.
Okay, I understand. I just want to keep the issue front and forward.
Okay.
Next is a request the amendment of Rural Health Clinic Regulation 907 KAR 1:082, Section 9(1)(b)(2), to extend the time to 3 days for providers to sign Medicaid participants charts. The current regulation requires only 1 day. So where are we with that?
That is still on the list of regulations. We haven't filed yet. It's been going through. We want to ensure that all the regulations align. And so we've been undertaking that review. I would like to note, so there, we plan to file it. We're not enforcing the current reg requirement of a day. And so, the department believes that although it's currently in the regulation, the physician's regulation, it says providers for 3 days. And so we're okay with providers utilizing that as the standard. I do want to note that we have 60 regulations that are on the list to be amended. They haven't even been filed yet. 60 regulations. And we've got 11 currently in the pipeline, already filed and going through the process. So I just hope that kind of helps you understand the difficulty of sometimes moving these along quicker than I think I'm sure would you all would want us to, but you're welcome to keep it on the agenda, but we've just not yet filed it yet.
Okay. Okay, well, we'll note that and know that you're going to change it, and I'll just keep it on the agenda so that when it does change, we'll finally know about it.
Sounds good.
Okay, next up is just a reminder of update and missed and canceled appointments, and how is the reporting going, and is there any consensus or common thread for showing up on appointments? So This is just a reminder that that'll be on the March agenda. Okay, and then next up is a discussion about continuing Zoom meetings for the MAC past March. So I'd like to hear from the MAC members on your thoughts on that. Anybody?
I'm okay either way. Either way is fine with me.
I'm okay either way. Zoom is really convenient.
Yes, it is.
Dr. Britton.
Yes. Somebody say, I'll say something.
This is Dr.
Dr. Cooper, we can't hardly hear you.
Can you hear me now?
A little bit better.
I just wanted to say, is there a way that we can make that call in March? As things seem to change rapidly with COVID?
You're going in and out, Dr. Cooper. I'm sorry.
I'll write it down.
Okay, sorry. Could anybody else hear it? Could have just been me.
No,
No, I think there was just a whisper. I think her sentiment was basically waiting for the situation to develop and kind of reassess closer to time. Yeah, it looks like the sentiment. Yeah, I certainly prefer the in-person meetings, but one concern would be, and Charlie, maybe you could speak to this, as far as a safe facility to do it. I think with I would probably propose continuing Zoom through March and reassess for May.
And that is one thing, Dr. Roberts. We do have the equipment now purchased that we could do dual in-person and via teleconference. We haven't been trained on it, so of course, hopefully that they're trying to get that set up right now. The MAC has grown. It is up to, I think it's a total of 22 members now. So the meeting that we were meeting in room 125, I don't think we can get 22 of you at those tables. So I was going to speak with someone over at LRC to see if there was one of the other rooms that the legislators meet in, and see if there would be the ability to get a room that all 22 of you would be able to sit at the front of the room in case everyone showed up at one time. But I think probably because for March, LRC will still be in session and they always have precedence over meeting rooms and so forth. So I think it probably is a good idea to keep for March and then reevaluate. That's just my personal opinion and on that part, but it seems like the consensus is waiting until March.
I would agree with that as well, Charlie. I think we should do the Zoom meeting for March and then assess where we are at that time. And because the General Assembly will still be in session in March, it might be difficult for us to find a room anyways, but we want to be safe and we certainly don't want to be super crowded in these times with COVID. It makes me a little bit nervous. So we'll go ahead then. It seems like the consensus is to meet by Zoom in March and discuss again in March where we'll do. Is that right?
I
I would
agree.
agree.
I agree.
I agree.
Okay. Thank you. And Teresa, did you get that Dr. Gupta is with us now?
Yes, she was on the list already.
Okay, thank
I think Dr. Bobrowski is on, but maybe wasn't earlier.
Okay, I did not get him earlier, so I can mark him. Dr. Bobrowski is present.
I thought I saw him on the participant list.
He might not be unmuted, so.
Yep, I got Donald's iPad. I believe that's him. He must be having.
Okay. Well, then we'll add him onto the roster as well. Next up is something that we talked about at the last meeting, is the MCO incentives for COVID vaccine. And after that meeting, we were sent a graph or a table showing what the different MCOs provide as far as incentives to patients. And so I just have a concern about this because I want all of the Medicaid participants to be able to have access to these incentives. And I think that because of the way some of them are set up, they don't. And so I'm hoping, I'm going to speak to these individually. And if anybody from the MAC also has reviewed the list and wants to add anything after I talk to the issues that I saw, feel free to do that. So first up is a question to Aetna. They have a provider incentive for value-based providers. And I was just wondering how the providers will receive that. Will there be some notification, or will there be some kind of line item for those providers who receive that they know that they've received that incentive? Is there somebody from Aetna on the call?
Can you hear me? This is Cindy Arflack from
Yes.
Aetna.
Yes.
They will receive those after it's from the claims. It has to come from the claim. So there's a little bit of a lag. There will be a little bit of a lag on those payments because we have to do the claims reports from those. On the member side, we're able to get those from the vaccination immunization registry. So we get those pretty quickly from from DMS. They send those vaccination immunization reports pretty quick. But from the provider side, we have to look at the claims report. So there may be a lag in those reporting. Is that what you needed?
Yes, that's the answer that I was wondering about.
Right.
And I also like to compliment Aetna on the ease in which the participants receive that incentive. The only thing I would like to say is maybe in very simple language, say this card is for you, it's your incentive or something like that, because I've had some patients show me the card and didn't understand what it was. But once they found out what it was, they were quite excited. And I think you've made it pretty easy for the patients to receive that. So I'd like to compliment you on that.
Oh, thank you. Well, we'll take that back and see if we can make it a little bit more clear of that this card is for their use.
Okay, thank you.
Mm-hmm. Thank you.
Next up, Aetna. And for Aetna, the incentive card is for retailers and different restaurants. And I have to say that once we looked at it through our practice, when a patient came to us and asking us what it was and how to do it, in rural areas, the incentives or the discount cards are not to places that are available to people in rural areas. And so, people just don't have access to those same places that are available in urban areas. And so I would maybe ask that Anthem relook at that. And if you decide you still want to provide discounts rather than a straight monetary incentive to people, think about the places where they can use those discounts, because that isn't a benefit to many, many people in rural areas. And then the other thing is that there is a phone number to call, but when you call the phone number, you have to be able to access it on a computer in order to get the discounts. And I know many of my patients don't have smartphones and they don't have computers. And even if you said, well, you can go to the library and use the computer, they don't know how to use a computer. So this isn't really a valuable incentive to many people. And so I would ask Anthem to relook at that maybe and see what you can do to make it friendly to recipients.
Hi, this is Jeremy Randall with Anthem. I'm not sure if you were looking for feedback to these points, but I'm happy to provide if so.
Yes, go ahead.
Okay, thank you. So to your first point about the retailers that we have available through our Healthy Rewards program, that feedback was considered, and we have made some modifications to the program to remove retailers that really are not available statewide, and to make sure that the discounts or the gift cards we offer, are for services and products that can be accessed, throughout the state. So, the point was well taken, and we have, made some modifications as a result.
Okay.
And to the second point about registration, we do require our members to register with the system to earn these redemptions, to get the redemptions. But that can be done through, telephonically, through our member services line. And so, when that point was raised previously, we did take that feedback and made sure that, our call center staff is able to, respond appropriately and guide members appropriately when they are, calling about Healthy Rewards registration.
Okay, thank you. I haven't had a patient ask me about that since the last meeting, the last MAC meeting. But at that time, we called for the patient because they didn't have a computer and didn't have a smartphone. And they did have to use the computer, and we did that for them at our clinic. But many other people, wouldn't take it to that extreme, So I'm glad.
I agreed. Yeah.
I'm glad you fixed that. Thank you. Okay, next is Humana and the rewards information. People have to go online to receive that. And so again, my same point. And then the gift cards are for a variety of retailers and restaurants. And so I was wondering what those retailers and restaurants were, again, going to my same point of availability in rural areas. So was there somebody from Humana here that could speak to that? Okay, it appears we don't have anybody from Humana. Charlie, would you mind reaching out to?
Hey, this is Kristen. I'm from Humana. I just joined, sorry. If you give me a second, I can pull, if you want to circle back, I can pull up who the retailers are. I just don't have that handy.
Okay.
So if you want us to send you that, we can submit that.
I'll circle back to you here in a minute.
Okay, thank you.
Okay, and then Passport made it pretty easy, and the gift cards were available to Walmart, Amazon, Kroger, and CVS, and those places are generally pretty available to people throughout the state. There's an accessible Walmart, I think, pretty much everywhere. So I think that was good. And there was a phone number for people to call to receive their incentives. So that was also good. For United Healthcare, again, the gift card was to Walmart or CVS, which is pretty much available to people throughout the state. The only question I had was that it said the incentives ended December 2021. Is that correct? From anybody from United Healthcare?
Hey, good morning. This is Ashley Hobbs. It has been extended to the end of Q1, and then we are meeting internally to see about extending that later down the year.
Okay, so extended to March.
Yep, 3/31.
Okay. Thank you.
Mhm.
And then WellCare. Again, the incentives were available to Walmart, which is generally available to most people in the state. However, people had to access the internet in order to get that. And again, I'll go to my same point. Is there somebody from WellCare here who would like to address that?
Yes, yeah, thank you. I will definitely take that back to the team about adding a phone number for certain. And an FYI, tomorrow we're going to launch a provider incentive. It'll be $40 per member. It'll be a one-time lump sum payment for a first vaccine. And it'll be through, begins tomorrow. And but it's for anybody that's been had the first vaccine since January 1. And it'll be through September of this year. And also our current incentives for members, we're going to continue at least through September. But yeah,
Okay.
I will definitely take that back about a phone number.
Okay, thank you.
Sure.
Okay, and then we're circling back to Humana.
I'm still looking through the document, scrolling to find out the actual the retailers for the gift cards. I need just a minute more.
Okay.
And I do know that we have Walmart on our list, I believe, but we can get you the rest of the list as well.
You do have Walmart?
Yeah.
Okay. Okay, very good. So the only issue would be then with the only, excuse me, only able to access it online. And I would ask that a phone number be added so people could access that.
Yes, and we can follow up and send this to Charlie so she can distribute and make sure that we get you a follow-up on progressing to a phone number being available. And of course, they can always call our customer service phone number as well, and they can pull up that information for them. But we can make that more clear in what we have out for people to see.
Yeah, because people people have trouble understanding the letters that they get anyways.
Yes.
And then to have them have to make that extra step of calling customer service, that probably won't happen. So
thanks for bringing that to our attention. We will get a follow-up note back to Charlie to send out to you all.
Okay, thank you very much.
Thank you so much.
Okay, and then next up is just a reminder that we will be having an update on the maternal infant health at our May meeting. And I'll put that on the agenda for the next meeting, but that's just as a reminder that it will be coming in May. It just helps me to keep things in my head that what we're supposed to be doing in the future. Okay, so next up, updates from the commissioner, and I understand Veronica Cecil will be giving that to us today.
Yes, good morning again. And I just want to note on the vaccine incentives to the MCOs, please definitely update DMS whenever you all are making changes so we can update the incentive spreadsheet and get that updated on our website as well and send back out to the MAC and tax. So we should be regularly updating that as things change, please. The commissioner apologizes for not being able to be here today. She had several conflicts, including a call with CMS. But I know she generally gives a first just sort of snapshot on enrollment. And again, this is just a snapshot, but as of Monday, we have 1,613,858 members in Medicaid. approximately 1.4 million of those are in managed care and 150,000 in fee for service. We have approximately 590,000 in expansion and almost 30,000, 27,921 in our SKY program. I also wanted to mention, since our last meeting, we did have open enrollment. And for open enrollment, that just gives our current Medicaid members the opportunity to change MCOs for no reason, no cause. And as part of open enrollment, we had 9,260 changes, MCO changes, as a result of that. I'm sure everyone knows by now, but just in case, the public health emergency was extended. So the Secretary for Health and Human Services extended it another 90 days, which is the only, he can only extend it 90 days at a time. It currently expires on April 16th. So we obviously were very happy to see that happen, and that we can continue with the flexibilities that we're currently operating on as part of the PHE. We continue to get an assurance from CMS that they'll give us 60-day notice before a PHE expires. So for instance, if they do not plan to extend it beyond April 16th, we're supposed to get 60-day notice of that. The reason for the notice is because there's a lot that has to happen with unwinding. And we're working with CMS. And right now on an unwinding plan, we're going to be working with stakeholders on what that should look like and how we should communicate it. But I assure you that we will have an exhaustive communication plan. I think it makes all of us a little nervous about when that happens, and not only for current Medicaid members that are on because of the maintenance of effort, and we're not allowed to terminate anybody. So the redeterminations that have to happen, but also providers who are operating under those flexibilities, and how does that affect you? So just want to note that we're trying to be very thoughtful and intentional about how we unwind, and we'll be communicating that as our plan is developed and finalized. The commissioner did want me to let you know that she'd like to, in the March update, provide an overview of 2021. And so she plans to come prepared to let you all know kind of, what happened in 2021 for Medicaid. We wanted to take a moment to talk about updating our quality strategy. And I'm going to tap Angie Parker, who is working on that effort for us. If you could please come on and give us a little update around that.
Good morning, everybody. I am on my phone because my internet went kaput during the middle of this. So I'm hoping you can see me and hear me. I don't know. I'm assuming you can. Okay, great. Again, I am Angie Parker. I am the Director of Program Quality and Outcomes within the Department for Medicaid Services. And the quality strategy, this is something that is a requirement of CMS, but I'd like to think that we would do it regardless, because it is very important for all of our members to receive quality of care. And in order to make sure that we are all accountable and doing this, we are developing or updating, I should say, our quality strategy. The last one was in 2019. And since then, that document, as soon as it was written and submitted to CMS, it was out of date. So CMS requires us to do a look back with that 2019 strategy, as well as where we are now and where we need to be. As part of that quality strategy development, we have enlisted the assistance of Northern Kentucky University's Health Innovation Team to help get this written and actionable before the end of the year. We have an internal interdisciplinary team that will be working on this along, and with that, with personnel from DMS, our MCOs, and other areas within the cabinet that will be consisted of that interdisciplinary team. But with that, we will also be enlisting the assistance of our TAC chairs to be interviewed. I know this is the first you've heard that, but we will get that information out to you. And we would appreciate it if you could participate in the interview process. That would be, it would be, the invite would probably be coming from Gary Ozanich from Northern Kentucky University, but DMS will be participating in those calls as well, or team meetings, however it is set up. But, and if a MAC member would like to participate in the interview process, we would welcome that as well. But this is going to be, we're kicking it off. We've already had our internal discussions with Northern Kentucky University. We're kicking it off in our interdisciplinary team on February 7th. So after that, you will be receiving, our TAC chairs will be receiving some information regarding getting interviewed for this process. We look to have at least the initial document ready by August for public comment. And then we'll have it sent to CMS for their review and approval for by 2023, if not before, hopefully. But a lot of what the quality strategy includes is objectives for monitoring and improving care services, population and quality improvement strategies, articulation of a vision of health delivery reform, and a roadmap for achieving these goals. Because it's, you know, it's all fine and good to have a quality strategy if we're not going to make it a workable document. This is not what this is about. This is what we need to look at as a Medicaid department, as well as statewide, on how we can continue to improve the quality of care that we are providing our Medicaid enrollees. So more to follow. And again, if I'll have Charlotte asking the MAC members if they would like to be interviewed as well in this process, and we can give you a little bit more information. But that hits the highlights of what there is to come regarding the Medicaid managed care quality strategy. Any questions?
Angie, I have a question. What will the interviews be looking for? What will the interviewers be looking for when they talk with the TAC chairs?
Well, that is it's probably be very high level in general of what each area or chair would be wanting to see as far as quality strategy for the Medicaid population.
Okay.
It shouldn't last more, I wouldn't think, more than 30 minutes. It could go, depending on what you want to say as well, it could last longer. But if you want to participate in some of and giving your opinion or thoughts on what Kentucky Medicaid should focus on as far as within our quality strategy, that's what, as a high level, what we're looking for.
Okay.
And,
and
and just Dr. Pardo, we're just still developing how that's going to look. I'm sure there'll be an agenda, or at least maybe some questions shared to prompt the conversation. But that's still kind of under development.
When will the interviews take place? You may have said that and I just missed it.
Well, we're meeting internally on February 7th. And then I would say sometime in February and March that the interviews would take place within that time period.
Okay, so the TACs need to be thinking about that and what they might want to say.
Like I said, this is the first they've heard of it too. This is hot off the press. So there will be more information on this to all the TAC chairs and to the MAC regarding this, but we wanted to bring that here to you today so that we can have a broad audience on what we're trying to achieve or working toward to achieve with the quality strategy. And we need everyone's input. Now, we do know we can't boil the ocean as far as, but there are certain things that CMS, does look at, access to care and those types of things. But there will be more of a roadmap for you in those questions and interviews.
Okay, thank you. And I'd like to say we appreciate that, reaching out to the TACs and the MAC on this, because I know we all want to be involved in these kinds of things. And so we appreciate that opportunity.
Welcome.
Okay. Oh, yeah. Any other questions on that particular piece? Okay. And then the next thing we wanted to talk about was to give an update on our efforts around mobile crisis. And so Leslie Hoffman, I believe, should be on to provide that update.
This is Leslie, I'm on. And I put a notice in the chat for everybody if you want to see where it's located on the DMS website. Just wanted to give you two updates. One is on mobile crisis. I think I've been here before and spoken about the mobile crisis planning grant. DMS and DBH-DID joint partnership to develop a planning grant submitted to CMS through ARPA, and we received it on effective 9/30 of 2021. The planning grant will run through 9/30 of 2022. So it's just a 1 year extensive communication, stakeholder involvement, information, research, trying to plan of what we would like to do after this planning grant related to mobile crisis services. What we are looking at right now is an all-inclusive model where everybody, our sister agencies as well, have a vested interest towards an all-inclusive model for crisis services. We've all got little bits and pieces, but they're kind of fragmented, and we want to pull that all together so that we can give the best quality of care for the Kentuckians that need these services. And it's for anybody in crisis. So sometimes I get asked about diagnosis. It's for anybody that's in crisis in the community. So we've been looking at other states, other models that you may have heard about, like the Cahoots model. There's a really good model in Tennessee we've been taking a look at as well. So the pieces that we're working on right now, believe it or not, we've already submitted a first quarterly report to CMS. And so things that we were held accountable for, just to let you know, were to establish a director in the Department for Medicaid. So that's Leanne Fitzpatrick. You all may know her. She works a lot on the incarceration side, reentry, and also on our behavioral health team. We had to establish core teams and establish work groups, which we did establish our key personnel as far as the state goes. We have developed core team members, and we have also developed executive governance committees, which includes all of our sister agencies, commissioners as well. And then we've developed our community engagement stakeholder list. It's very extensive. We have probably over 200 people that we've identified in the state of Kentucky for either surveys, one-on-one interviews, as well as, roundtables. I think we've got 7 kind of roundtable or town hall discussions that'll be going on. My one major way of communicating is going to be through our behavioral health TAC. Dr. Sheila Schuster is going to allow that. So that was something that I really appreciated, but that'll be our one method that you can always try to get updates related to the mobile health crisis. So currently we're working on, communication, teams, outreach, interviews. Like I said, we did send out our first survey of 50, and this was we started out with internal stakeholders at the state level, and we've actually received 34 out of 50 with 12 pending, which means they've started it and haven't finished. That's really good. I'm always appreciative if we get more than 30% right. So that's a really good thing. So the whole mobile crisis will be developed to ensure that people receive the appropriate response when they're in crisis, to try to alleviate some of the police force involvement, and to assist with for appropriate placements, not those such as incarceration and or psychiatric hospitals. So we're really excited about this, but really this first year planning grant is just extreme communication and development about what our state needs. Sometime around March, we will have a completion of our needs assessment, which will have come from all the interviews, stakeholder meetings, involvement, and surveys that we completed. So that's the mobile crisis. And like I said, I did include that in, let's see, I'm sorry. That looks like that gave No, that's Charlie's. I'm sorry, I apologize. Charlie had an email or text after me in the chat. So I did include the mobile crisis document in the chat. And then one other thing that I just wanted to let you know about is, if you remember, we've talked about our Kentucky SUD 1115 incarceration amendment, and that's for pretrial members, those that are incarcerated, as well as those that will be leaving. We want to assist them in choosing the MCO of their choice the 30 days prior to their leaving, so that we can assist with having them ready, community ready, and involved and connected to all the partners in the communities that they will need. CMS did reach out to us. It was very exciting. It has been little over 13 months that we've been waiting, and they reached out to us with a couple of questions related to budget neutrality. We met with them last week, and they offered some technical assistance. This is new for everybody because it's the first one, in the nation that we've kind of tried to do budget neutrality in comparison on something that we don't have. So they've offered technical assistance, and we reached back out yesterday and accepted their technical assistance for the budget neutrality piece. So it's all very exciting. Again, I usually give updates on in the behavioral health pack as well. And there's a substance abuse task force. So they usually give updates on that information if you need anything else. So that's it in a nutshell. That's the mobile crisis and the 1115 updates.
Thank you, Leslie. Any questions about those initiatives?
This is Barry. I think it's great. We have a grant where we work with the jail systems here locally, and I think that's awesome news. It would be very beneficial.
Thank you. We're very excited about it. So thank you, Mr. Martin.
Okay. Then again, I mentioned that we've got 60 regulations, and that's ordinary and any potential emergency that needs to go with that under development, 11 in the pipeline. I wanted to mention that there is currently out on the street a request for proposals for our new, it's called the Medicaid Claims Administration and Financial Solution, or as we like to call it, MCAS. So that RFP is being procured right now. I mention it because that's a public document, but that will be a major implementation for us. It takes our legacy Medicaid management system, and we're doing a lot of things to improve it. And that making that switch will be a major undertaking for us once that gets awarded and we start to develop and implement that. There's about 52 other projects on our list, but that's just the highlight of what we're doing for now. Happy to take any questions.
Veronica, I have a question about the telehealth regulation that's out right now for comment. On the platforms that are going to be allowed after the emergency order ends, will providers and patients still be able to use FaceTime or Facebook Messenger as a platform after that?
Jonathan, are you on, and could you answer that question? And if not, then we'll be happy to provide a response to that. It's a little tricky because we, as a Medicaid agency, we're required to follow the Office of Civil Rights approved platforms. And what I'm just not sure of if those are on under that. So if Jonathan is not on, there we go. And if you can't answer it, Jonathan, that's fine. We'll get back up.
Certainly. Good afternoon. I'm Jonathan Scott, Regulatory and Legislative Advisor for DMS. The regulation is drafted, so it is, if the OCR allows for FaceTime and some of these other types of platforms, apps, if they meet the criteria, then they will be fine. But it's going to be in the hands of the federal government and OCR. We tried to draft it as broadly as possible, but we still have to follow their lead on HIPAA and some of the other concerns that can happen.
So Yeah, to
So-
answer your question, Dr. Parton, I'm not sure if we know specifically if that's current, if that's considered an approvable platform. That is on our list of one of the things we have to consider as part of unwinding. That would be guidance we would give to the providers on, with no longer having the PHE and those flexibilities, what is permitted.
Okay, and I guess that I couldn't understand reading the regulation if it would be, and I guess you all don't know either yet. So I guess my only comment would be, again, for patients that are using those platforms, I know my patients would have difficulty accessing other platforms. They've got their phones, and so they can do FaceTime and Facebook, but as far as doing anything else, I think a lot of them would have great difficulty. They have great difficulty anyways with those two things, but it would be even harder, probably impossible for some.
Yeah,
So-
and we recognize that, and I think that states have conveyed that to CMS certainly, and I'm certain that the Office of Civil Rights has heard those same comments. So, I think we're advocating for that to the extent that it's secure and appropriate, and so we're all kind of, I think, in the same boat with that.
Okay, thank you. We have an item on new business, but it'll go back to you, I guess, to answer that. So if everybody is agreeable, can we skip on the agenda down to that one item so that Veronica can answer that and be done with it? Is that all right with everybody?
Yeah, I'm fine with that.
That's okay with me.
Okay. So if no other objections on new business, one of the items was, would DMS consider looking at value-based payments tied to quality measures to equalize reimbursement for all providers? Right now, as you all know, there's a discrepancy between what providers are paid depending on the type of provider. And so I'm wondering if DMS would consider looking at that to equalize reimbursement across the board.
Short answer is yes. A little bit longer answer is that in our contract with the managed care organizations, we actually have provisions for value-based payment programs, and in fact, strongly encourage it. We are also, and this is a very timely question, we are also in the process of, working with the MCOs on improvement programs and other things, so that we're at least aligned in the outcomes that we're trying to achieve. But what I recommend for this, if you're open to it, is to ask the MCOs maybe at the next meeting to present on because they all have value-based payment programs. I think I think one of the challenges is finding providers willing to do it, because there are a lot of things they have to do to track the data and the outcomes. And so I think it would be, I would suggest that maybe we could have the MCOs at the next meeting give a very short presentation about what their value-based programs are like.
Okay, I'm writing that down.
Sure. Along those lines about payments, I will share that we've had 9 different provider types reach out to us requesting increases in reimbursement, some as much as 25%. And, we understand that we're all here to serve the member, but we can't do that if we don't have providers. And there are, we do though have a budget, and then we also have to ensure with CMS that there's some type of methodology to the rates. So that presents a challenge sometimes when providers just want a flat amount. it's hard to justify that to CMS. We're in the legislature right now. The budget is going through the process. We've encouraged groups that have reached out to us that they may want to discuss that with their legislators, so that any cost increase and increase in reimbursement is included in our budget, because that really is the limitation for us. So, we hear you, we hear the providers, we understand there's workforce shortages. We're experiencing it here in the department as well. Everyone's competing for sometimes the same workforce, and are wanting to be able to provide, higher salaries and find ways to recruit and retain. So we recognize that, and we know the struggles that are happening out there amongst the provider communities. I think value-based payment programs are helpful. It allows providers to distinguish themselves and to get increased funding to help offset some of those costs. So just wanted to share that.
Okay, thank you. So we'll bring that back to the next meeting. And I guess I think some of the discrepancies in the reimbursement are just arbitrary numbers. I can only speak specifically with knowledge as far as nurse practitioners, but it seems to me that reimbursing a nurse practitioner at 75% of a physician rate for doing the same treatment and having the same or better outcomes, that 75% just seems to me to be arbitrary and not based on outcomes at all. So hence the question. So I appreciate being able to bring this back, and we'll be looking into it further.
And so the only other thing I was going to mention was Charlie's retirement, but you beat me to it. We also are thrilled for Charlie, but also, it's bittersweet. She's just been a phenomenal representative of the department, and we're really going to miss her. We will keep you guys updated on the transition of her duties and who will be taking those over, but we will miss her.
Thank you. That was a question that I had. Who should we contact if we can't contact Charlie?
Yes, so we will definitely get that information out to you all.
Okay, thank you. Does anybody else have any questions? Okay, thank you very much.
Dr. Tartman, could I, just before you go into the TAC reports, can I say something? First, Veronica, thank you. But second, I've had a couple of people contacting me on private messaging asking if they can present a report for the TACs, and they're not TAC members. And I just wanted to remind everyone that the bylaws of the MAC state that the members of the TAC, either the chair or another member, must present the reports to the MAC. So we've got a couple that the membership has switched, and the MAC member is not necessarily on the TAC. So I just wanted to clarify that. Now, and what you all may want to consider in the future is looking at your bylaws and seeing what you want updated and so forth. So, but since I've had a couple of people asking me this morning, I just wanted to remind people that you must be a member of the TAC in order to make a recommendation. So I'll let you go ahead. Thank you.
Okay, thanks, Charlie. Having said that, what is the pleasure of the MAC? Do you want to look at amending the bylaws to allow a person, perhaps a MAC member, who is not a member of the TAC, to be able to present recommendations if the TAC people are not available?
I would be in favor of that, just because every once in a while something happens, if the TAC committee can't get everybody railroaded, especially during these times. I know it's really hard if their practice sites are really busy. So I would be in favor.
I totally agree.
I agree as well. I mean, it's for the betterment of the beneficiaries. So anything that speeds along progress, we should allow.
But one thing I would recommend that if they do present, that they should have, me personally, again, I'm not representing DMS here in this comment, but perhaps if there's going to be someone else, that they should attend the TAC meeting in order to make the report. But again, that's up to you all. You can do it however you want to do it. But a lot of times there's a lot of discussion around a certain topic at the TACs. And if you're not there at the TAC meeting and then you're expected to make the report, you don't get all, both sides that were discussed, or all sides, I should say, that were discussed and so forth. So if you do look at doing that in the future, you might want to consider if someone else is going to make it. If a MAC member, I would recommend that they at least still has to be a MAC member that makes it if it's not one of the TACs. But if they're not able to, that person, the MAC member should have at least attended the meeting so that they can have a clear understanding of what was brought up.
Charlie, I think that would be the ideal. However, I guess trying to look at unforeseen circumstances, if you can't know ahead of time that sometimes, I guess I shouldn't say all the time, sometimes you can't know ahead of time that nobody from the TAC will be able to present. And so I think I would be more in favor of saying if a MAC member was presenting that they could just read the recommendation and not to report. But of course, it would be ideal if they could attend the TAC meeting. But like I said, you can't know ahead of time sometimes that there won't be a TAC person to present.
Well, and most of the time at the MAC, or I'm sorry, at the TAC meetings, the chair does ask, or does state, I will be available to make the report, or if I'm not, can someone else do it? And then they assign someone else at the time. So, and I know there can be something happen, this morning that prevents somebody that was planning on being here at the meeting not be able to come. So, but I just want to throw that out there for you.
Right. I think that would be ideal. But like I said, if some unforeseen circumstance might prevent somebody from being in, even though they fully intended to at the time of the TAC meeting. And so whoever they asked to give the recommendation wouldn't have been able to attend the TAC. But we can look at that. We can't vote on it today because we don't have a quorum. But it seems to be at least the consensus of the people here today that we should amend the bylaws on that particular point. So I will put that on the next agenda and we can vote on that. Give me just a second to write it down. Okay, thank you. Okay, anybody else have any before we move on to the TAC reports and recommendations? Okay, and I did move on quickly to the commissioner's report after we did the MCOs for the COVID vaccines. And did anybody have any comments on that? Okay, thank you. All right, let's go ahead and go to the TAC reports then. And first up is therapy services.
I have not seen Beth coming in. But I know they did meet and they did not have any recommendations.
Okay, thank you. Primary care, podiatry,
Beth, Barry, were you going to give the? He may have stepped away.
I'm trying to unmute myself. I thought Mike Cottle was in here, going to give the report.
I don't see him in here. So if you don't have it, I mean, that's fine. I knew you were on the TAC and.
I am on the TAC. Unfortunately, I had to miss the last meeting, so
that's right.
I can update you on what went on.
Okay.
So we'll just have to not give a report for this quarter.
okay, thank you. Podiatry,
They did not meet.
physician services,
Can you hear me?
yes,
I don't see Dr. McIntyre on the call, but our meeting was last Friday, the 21st, and we did not have any recommendations.
thank you. Pharmacy,
Yes, can you hear me?
yes,
Okay. We met on 12/8 of 21. I'm sorry about my voice. We had a motion that was passed to ask Medicaid and MedImpact to exempt buprenorphine or Suboxone related products or MAT practitioners' prescriptions from the 23-day dispensing fee threshold. Testimony was given that 43% of Suboxone claims are reimbursed below our cost. And other people talked about the demand of these particular patients taking a lot more time and effort and scheduling. And most of the time they're giving us 7-day supplies, what they're just dispensing is. In the past 6 months, the reimbursement, the lesser than algorithm used for medication assisted therapy drugs has been greatly reduced, thus resulting in an enormous high percentage of negative reimbursement claims. Right after that, Fatima Ali stated in comparing, and I know that she's also evaluating some other reports currently, that Medicaid thought that we were getting paid adequately on these claims. And so therefore, regardless of the motion, we actually have legislators who are trying to address this issue with submitted bills in this session. Secondly, a motion was made and asked Medicaid and MedImpact to increase administration fee on non-COVID related vaccines. Unlike a nurse practitioner or physician's office, pharmacies don't have a office visit that we can bill for, and therefore the $3.30 administration fee doesn't even begin to cover just our liability in providing this. And with pharmacists administering 70% of the COVID vaccines in this nation, I think that tells, our worth during this pandemic is to get people vaccinated. So, and then unfortunately, a lot of the reimbursements for non-COVID vaccines, just for the product itself, the reimbursement is below our cost. So we've got a real issue there. And again, legislation has been submitted to try to take care of this issue. We also just had a minor motion, well, I mean, a minor topic of non-insulin syringes to be covered by formulary, because we have so many people that are paying Medicaid patients who are paying cash for supplies related to B12 injections, allergy shots, hormone shots, antipsychotic injectables, and on and on. We did discuss a brand name rebate. That problem is already taken care of itself. And then the last topic that was discussed was suggesting just starting the conversation with Medicaid and Med Impact. We've already started the conversation, but we were asked to put it off until 6 months after implementation, and that's where we're at. Where hospital pharmacists and prescribers are making the decision to treat their patients with superior compounded products when a commercially available product is either not available or not in the dosage form desired for given therapy, and it cannot meet the needs of the best treatment practice. Many times hospitals are losing on their preferred treatments in order to have patients attain the best outcomes. Hospitals are asking to be made whole for their knowledge, time, and liability that's invested in these favored compounded prescriptions. Community pharmacies are having to suggest inferior treatment therapies of commercially available products that Impact will pay for, instead of being able to compound the best treatment possible and be able to submit a successful paid claim for the compound. The majority of the products compounded are to take a solid dosage form and compound it into a liquid or suspension form for easy swallowing to assist patients who cannot swallow solid dosage forms. And that is my report.
Thank you, Ron.
You're welcome.
Any Okay, next up, persons returning to society from incarceration.
Yeah, good afternoon, good morning. This is Steve Shannon. I'm the chair. On the conversation with other TAC, MAC members giving reports on behalf of the TAC, and I put this in the comments, not all TACs have someone who's on the MAC to go to and from. So those TACs, like the persons returning to society TAC, would not have that opportunity if we could not be available to report if it was a MAC member. So some TACs would be left out of that opportunity if need be. So just an observation.
Okay, well noted.
Okay. We met twice. We met December 9th and January 13th. Both meetings, Medicaid provided an update. The December meeting, let's say Hoffman did it, and January, Leanne Fitzpatrick. And most of the information we heard about today from Medicaid, we discussed, including 1115 waiver. We also talked about a thing called CCBAC, Certified Community Behavioral Health Demonstration. It's a big deal. It's 4 CMHCs have this opportunity to move forward to join 8 other states nationally. We heard about an SMI STD waiver, something we've talked about a lot. You'll hear that again in behavioral TAC report. And we heard about the mobile crisis grant. Also, we had a presentation from Adrian Bush with the Housing Homeless Coalition about challenges people returning to society face in terms of housing from incarceration. We talked about a housing first model and what can be done, and recommended that the ACLU present on their efforts as well at our January meeting, which we did. And again, in January, we heard more about SMI waiver and the incarceration amendment we heard about today. I think the questions are favorable. It shows movement. But the big news, we had a presentation from Marcus Jackson at the ACLU of Kentucky. I would encourage you to invite him to the MAC and talk about his experience as a person who was formerly incarcerated and transitioning back to the community and the value of that, Medicaid in that, and really talked a lot about housing. How do you access housing and get a good place to live? He encourages people to use the right language. He likes currently incarcerated person and a formerly incarcerated person. And we talked about the 1115. He says reentry starts your first day of incarceration. So if you're doing a waiver, if you're looking at those services, you need to start talking immediately about those things. He encouraged people to talk about folks who are formerly incarcerated and how they access Medicaid, how long it took. Also, the release date is a hard challenge. The 30-day thing, it should help at the 11/15, up to 30 days from release, but that's not a set date. You don't know specifically. You get some time taken away for certain activities you may be involved with. So that's something you have to pay attention to. So that was our report. We had no recommendations at either meeting. We did have a quorum in December, did not have a quorum in January. And that's that report. Dr. Parton, can I go ahead and give the behavioral health TAC report for Dr. Schuster, or do you want me to wait? I can wait.
Let's wait, just
Okay.
to be fair to everybody.
All right. Thank you.
Thank you. Steve, at some point, if you would send me the name of that person, and then we can see about getting that on the agenda.
Okay, we'll do.
Thank you.
for that.
Okay, optometry. Nursing services.
Beth, they did meet, but I'm not.
I'm here. I'm
Okay.
here, Charlie. It's
Sorry,
Lisa. I
Lisa.
couldn't get myself off mute. I'm sorry.
You're
We
fine.
did meet and we are working on some things, trying to get more information. Focus is midwives and reimbursements and looking at making an effort to decrease the disparity in maternal health for Black and brown populations. And we have speakers lined up for our meeting, and we are meeting next week.
Okay, thank you, Lisa.
Mm-hmm.
Next is intellectual development and disabilities.
Beth, they did meet. They did not have recommendations, and I don't see anyone here from their tax. I'm thinking that might be why they're not on here. But Dr. Compton, he's on the optometric tax. I don't know if he could not get off of mute. Or maybe I know they've met, but it's been a while. It may have been before the last MAC meeting, so that might be why he's not saying anything. Okay, maybe he's not. All right. Dr. Compton, we're not hearing you. You've unmuted you've muted yourself. Perhaps, Beth, you can go ahead to the next one and we'll see what's going on with his.
Okay. Okay, hospital care.
This is Russ Rinaldo, the chair of the hospital TAC. The hospital TAC met on December 15th. We had a quorum. We do not have any recommendations, just to a couple items to note from the report. We had a hospital rate improvement project update. The HRIP for 21 was extended through the end of December of 21, and the first quarter notices went out to the hospitals the second week of December, and DMS is working with CMS on the 2022 calendar year approval. There's actually a conference today on the quality measures for that year. The TAC discussed a recommendation made in November by the Severe Mental Illness Task Force to the LRC about covering the cost of a long-acting injectable antipsychotic medications, which could and would probably be giving at the end of an inpatient stay. The TAC asked CMS if they were going to adopt that or looking to adopt it, to consider the cost and possibly adjust the reimbursement for the psych hospitals to cover that medication. There were some other items, but those are the two highlights.
Okay, thanks, Russ.
Thank you.
Home health.
We had to cancel our meeting because we did not have a quorum. We are presently working on our next agenda and hope to have some recommendations at the next MAC meeting.
Okay, thank you. Nursing home care?
They have not met since the last MAC meeting.
Okay. Dental?
Dr. Bobrowski, are you here? You must not be here, Dr. Barton.
Okay, thank you. Consumer rights and client needs?
Good morning, everyone. Excuse me. I'm Emily Beauregard. I'm the director of Kentucky Voices for Health and the chair of the Consumer TAC. We met on December 14th remotely, and we had a quorum, which was great. We discussed the Medicaid open enrollment, and it sounds like things went pretty well with people choosing, to switch their MCOs. Didn't hear a lot of issues with that, so we were happy with that report. We also pretty extensively discussed Connect open enrollment, the marketplace open enrollment, which, as you, I think, probably all know now, we have reintegrated our state-based marketplace with Connect, so all of the other benefits along with the qualified health plans. And while that's fantastic for Kentuckians in a number of ways, having that streamlined process, there have been a lot of issues with enrollment just in the past couple of months since this launched. The soft launch was October 15th. And so we expect always that there are going to be some wrinkles. We've really appreciated, of course, that KHBE, the Kentucky Health Benefit Exchange staff, as well as the Deloitte consultants, have been really responsive to errors that people are running into and working on those to resolve them. But we do see some kind of larger design issues with the system that have not only impacted people who are enrolling in qualified health plans and shopping for those plans, but it's actually affecting people enrolling or recertifying for any benefit offered on Connect. So Medicaid included, of course. And Medicaid, touches the most people who use Connect. So that is a concern of ours, one that we want to really keep an eye on. And we have, been reporting issues to both DMS staff as well as the Kentucky Health Benefit Exchange and the Deloitte team. And there's an issue tracker that's been useful. We've also, been reporting things to the help desk at times, but feel like there's really an opportunity to make this platform more streamlined for all benefit programs and a little bit more intuitive. My biggest concern right now, knowing, I think Veronica mentioned earlier that we do have that MOE in place, the maintenance of effort rule, which during the pandemic, the public health emergency, almost everyone who has been enrolled in Medicaid since the beginning of this pandemic has stayed enrolled in Medicaid, even if their eligibility may have changed or maybe some information just needs to be updated that hasn't been. And with that unwinding that she talked about, as people are having to recertify for their benefits, if some of these issues are still in place, I think it will be much harder for them. So we really need to make a concerted effort to make sure that the system is working well for people as they are uploading documents, just doing anything that's required of them to keep their coverage. And address changes, address updates, I should say, are a big part of that. And we know that during the pandemic, a lot of people have moved. A lot of people have unfortunately been evicted or have had, other reasons for needing to move during the pandemic. And of course, it's now spanned nearly 3 years. So there's been a lot of movement just for that reason, just a matter of time. And having people, having mail that gets returned to the cabinet can prompt, people being disenrolled from Medicaid. So there are lots of ways in which I think we need to be educating people, preparing them but also making the Connect system, the online system, work as well as absolutely possible. So I think after open enrollment ends, which is, it's been extended to the end of this month, I'd really like to see over the next few months an effort to do some design updates and make sure that, it's not taking people twice as long, which is what's happening now. Connectors are reporting to us that it takes about twice as long for someone to complete a Medicaid application. There haven't had to be a lot of recertifications with Medicaid. So, that is kind of an open question, what's that going to look like? But with that state-based marketplace piece being reintegrated into the system, for some reason, the way that application process is working is taking people twice as long and is just not as simple and streamlined as it was. So that's something I want to just get on everyone's radar and make sure that we are, working to make that better between now and the end of this maintenance of effort, as well as next open enrollment period at the end of 2022. And so that's something we're going to keep addressing through our consumer attack meetings. We'll continue reporting those issues. And if you're hearing any of those issues, we'd like to make sure that we're capturing those as well. Another topic that we discussed at our December meeting was DMS's response to the devastation caused by tornadoes in Western Kentucky, which it's hard to believe that really wasn't so long ago. But just want to say thank you to Pam Smith and to others who, come and reported our TAC meeting, but also who are doing the work at the cabinet and within the Medicaid program. Pam specifically had reported, that they were checking on all 1915C waiver recipients to make sure that they were okay, put a lot of flexibilities in place and rate increases in place for providers so that they could better serve their clients during that time, and even facilitated, expanded services such as meal delivery. And so it's just really, really nice to know that we have programs in place and that with these flexibilities and staff who can, sort of pivot when we have disasters like this and need to respond so quickly. Finally, the last topic that we discussed was network adequacy. TAC members expressed some concern about a report that was commissioned by DMS and apparently happens every year through our third-party QRO. I think I just got that wrong, but it's iPro, and they do the quality review for DMS, and that's a requirement of CMS, the federal government. So they commissioned a secret shopper survey to call various providers who are Medicaid providers, or at least, enrolled with Medicaid as a provider, and ask questions about their availability for appointments. And we have in Kentucky, both in statute and in regulation, requirements for network adequacy, both in terms of distance and time. And so, the secret shopper survey asks how quickly someone can get an appointment, and of course looks at availability throughout the state for different types of services like primary care, OBGYN, et cetera. And the results were really, really terrible for Kentucky, unfortunately. Now, this was happening the end of 2020, so it may be somewhat related to the, the pandemic, but I think it was anywhere between about 20 and 40% of the time there was an appointment within those standards, within the time standards or the distance standards or both. And that tells us something, that, a lot of people, especially living in rural areas, don't have access to the providers that they need, and are probably discouraged sometimes from getting the services that they're looking for. And so, this responsibility is placed on MCOs. MCOs are responsible for having an adequate network, but a missing piece, I think, or one that could be strengthened, is the enforcement. So now that we know, that these MCO networks aren't necessarily meeting the needs of Medicaid enrollees, what are we doing to make sure that MCOs are being held accountable and are at times providing out-of-network care, approving providers that would otherwise be out of network if those time and distance standards aren't being met. And we know that most Medicaid enrollees don't know what their rights are, don't probably know the rules for time and distance standards, and don't know what to do to request that out-of-network provider when they need it. When we looked at the MCO handbooks, they were all a little bit different in terms of how they address network adequacy. And for the most part, the guidance to the member is call the customer service line or the member services line. And when someone calls the member services and they're told the various choices that they have, I don't know that they necessarily know what to do if none of those options work for them, if they're all too far away or if they're all too far in the distance. And so having, I think, more information for consumers on what their rights are, what the standards are, and what to do if they aren't finding someone in their area who meets those standards, how they can appeal that decision, how they can, actually file a complaint or a grievance with DMS if necessary. I think that's really critical. And so we discussed that and talked about having some type of simple one pager for consumers that would give them more of that sort of information and what to do. So the two recommendations that we made for today's MAC meeting for your consideration, the first was actually based on conversations that we had at previous meetings. So not something we really discussed very extensively in December, but that recommendation is for DMS to amend the state plan to lift the 5-year bar on covering legally residing pregnant women. So these are women who are here for various reasons with, a visa of some sort, and when they're pregnant, aren't able to access Medicaid if they haven't been in the country for more than 5 years. So we think that it's a population of people who, are high risk if they're not covered with insurance when they're pregnant and having those babies. And we have that option through CMS, but it's a state option and we have to request that we lift that bar. Our second recommendation is that DMS work with the consumer TAC to develop a one-pager on network adequacy. So those are the two recommendations that we put forward for your consideration. And finally, we also voted on our schedule, our meeting schedule for 2022. And I put those dates in the report. They should be on the website now. And I think that's it for us. Happy to answer any questions if you have them.
Okay, thank you, Emily. Okay, next up, Children's Health. Okay, and last, behavioral health. Steve?
Yep, Steve Shannon, giving it for Sheila. She's not available today. We met, and I am a TAC member. We met January 13th. We welcomed a new TAC member, TJ Latefik with NAMI, Kentucky. The other person's no longer with the organization, and we had a quorum as well. We approved the minutes from our November 3rd meeting. And we had a response from DMS, a recommendation made in November MAC meeting, and reviewed that as well. We're pleased to report DMS has agreed to pull data requested on individuals who have covered both Medicaid and private insurance. Dual eligibles, there's some problems with some behavioral health providers getting paid for those services, especially behavioral health. There are some services Medicaid paid for that commercial insurance does not pay for, target case management. So we'll never get an EOB from a private insurer for a service they don't cover anyway. So we're trying to figure that out with our MCO partners as well. We also received some data from DMS regarding targeted case management. We got that about a week before the meeting. We're going to review that data and see the impact of targeted case management going forward. We had a discussion around EMS transportation. House Bill 296 was filed this session to make that available. We have some concerns with hospital transportation with people with a behavioral health issue. We really feel this is a parity issue. Physical health gets transported by an ambulance. It doesn't happen necessarily for people with behavioral health problems. After discussion of the Medicaid formulary, no questions, but we appreciate Dr. Ali being present. Leanne Fitzpatrick, reporter for Leslie Hoffman, very similar to what we've heard today on the 1115 waiver. And the questions from CMS, which we think are as encouraging as that moves forward. Had a conversations about the data relating missed appointments. We had some concerns how that is going to be used by the MCOs, and they reported they're still collecting that data and looking at it. They don't know which provider it was necessarily. They know the individual and the missed appointment. I think they're going to try to get that information from DMS to the MCO so you can look at it by provider about missed appointments. Our concerns with that information is, would that be somehow, this individual, Steve, misses a lot of appointments. Let's put him on some other program to make sure that doesn't happen. And is that unfair? Is there some rationale? So we just want to understand how that was used. I think knowing the provider will help as well, because we can target that information to going forward. We had additional information about apparently a lot of behavioral health folks have had increased audits from MCOs. Medicaid clearly stated that is an MCO function. CMS wants to see audits. The concern expressed, and as I represent CMHC, several mental health centers, it's a huge amount of information requested at one time. We were advised you could negotiate with the MCO, and maybe not negotiate, but let them know it's going to take us longer to get you that information. You're requesting a lot, so instead of getting it in 2 weeks, it may take a month or 6 weeks, but the audit is required to look at what's going on, so we understood that. Dr. Schuster provided an update on the SMI task force. You heard about that from the hospital care TAC as well, and some recommendations, which include an SMI waiver that would include supported housing and supported employment. I've said this at many meetings. If you're in one of the waivers, the IDD waivers, if you're an hour late on medication, that is an event that gets reported to the cabinet. If you are severely mentally ill and don't take your medication for an hour, a day, a week, a month, no one knows it. I suspect family members and law enforcement find out first. So part of that residential option would make sure medication is taken as prescribed. Also more funding for mental health courts, which I think is invaluable across the state. And we had a brief discussion of the 1915C waiver task force, which also included an SMI waiver in that discussion as well. Had a bill grid. We had no recommendations going forward. We did get an update on the prior authorization. That's, there's no prior authorization for behavioral health currently. And our next meeting is March 10th. And I would like to echo what my friend with the consumer TAC reported as well about the efforts on the tornadoes and the 1915C assistance provided. Emily was right. Medicaid was helpful, assisted providers with identifying people, going to homes. Unfortunately, an individual served and supported by one of the mental health centers in the west part of the state died during the tornado. The house was destroyed. Another person thought would be perhaps died from that, but was okay. And they're back out of the hospital now. But we do appreciate the support provided to the behavioral health community in those impacted counties by other professional groups as well as the cabinet as well. And it's moving forward. So that's the report. I thank you all.
Thanks, Steve. Any questions? Okay. So that concludes the reports and recommendations from the TACs. Teresa, have we picked up enough people to have a quorum?
I checked the participation list and we still do not have a quorum.
Okay, thank you.
We need 10, we have 8.
Okay. So unfortunately, we cannot vote to accept these recommendations, and we will have to do that at the next meeting. And what that means is that there will be no response from DMS to the TACs until we can vote to accept these recommendations at our next meeting, which will be in March.
Beth, I'm sorry. I've lost my voice. We can respond per the MAC bylaws when they were done. But you all were having some problems having quorums. And so the department agreed, and we put in the MAC bylaws that even if the MAC did not have a quorum, we would still respond to the TAC recommendations. So we will be responding to them. They don't have to wait another 2 months. I'll be getting those out here definitely before I leave. But yeah, we will be going ahead and doing those.
Okay, thanks, Charlie.
You're welcome.
That's good news. Okay, so moving along to new business. We've already addressed one item. The next item is every year we get updates and reports from the MCOs, updating the MAC members and the community at large on what is going on with the MCOs. And so I would like to go ahead and set some dates for some of the MCOs to come and give a report. And as far as what to include, Charlie, I don't remember exactly everything that we asked before, but I'm sure you have that list. So I think that the information that was provided in the previous reports was helpful. And so I would like to ask that we include those in the request to the MCOs to include in their update to us. And then I would like to ask if the MAC members have anything specific they would like to have the MCOs report. And then also if DMS has anything that they would like the MCOs to include in their reports.
And Beth, you're right. What the MCOs can do, of course, they should still have their report from last year, but we also have it out on our website, and they can just update those reports. I mean, that presentation. That way you all have a continuing year after year analysis of what's going on. So that's one thing. I just want to let you know that we would like to just update those presentations.
Okay, that sounds good to me. Does anybody have anything else that they would specifically like the MCOs to provide information on?
I would like a little information on their prior authorization lists. Specifically in my instance, it's not as much medications as it would be, primary care, behavioral health kind of issues. But for procedures, perhaps their top 10 most frequent requested prior authorizations, or are there procedures that are there's a specific reason they're requiring prior authorizations that are kind of common sense things. Perhaps just a little window into how they select what procedures are requiring prior authorizations.
Okay. I'm writing this down, just a second. I think that would be very helpful information. Okay, anybody else?
Can you hear me?
Yes.
I just want to make sure I understand correctly. The question is, what else we can ask MCOs? Is that correct? About prior authorizations or anything in general?
Yeah, I just want a little more, transparency into their process of why they're requesting prior authorizations for, given services. I mean, if you have a $500 medication and a $20 medication that do the same thing, okay, you probably need to justify that one. But, a diabetic comes in with a wound, I debride it. That's the standard of care. That's a common sense thing. and it gets denied for not, there's no reason to have a prior authorization on that service.
Right.
I mean, there's not even time to get it. You know, the patient comes in with this thing that, you know, that reeks and has drainage coming out of it. Well, hang on, let me get in touch with the insurance. No, that's ridiculous.
Right. On that same note, I was wondering if the MCOs would consider waiving prior authorizations for providers who have shown for a certain number of years, you know, they can define how many years that is, of basically not abusing the system, showing that they have, you know, validated those procedures, all those prior authorizations were eventually approved.
Yeah, I really valid point. Just another example, I think, is a patient that I would see in primary care that needs a referral to neurosurgery, and they have prior MRIs that show that there's a problem, a significant problem, but they were done more than 6 months ago. And so in order to get them to the specialist, we're required to get another MRI, and we have to get that pre-authorized. And we already know that there was a problem because it was there 6 months ago, and it's still there, and it's worse. And we have to go through days and days and weeks, sometimes trying to get pre-authorization for an MRI on a patient that we already know has a specific problem. So I think this information would be very helpful for us to know, and maybe to give feedback to the MCOs.
When we did discuss the prior authorizations at our last meeting, and you know, some of the feedback was that there's too many providers out there that don't follow the guidelines, and that's why, you know, they don't want to do away with prior authorizations. But there's plenty of providers that do follow the guidelines and practice, you know, good medicine, probably the majority of providers. And if there is some way to track, you know, review maybe their past 10-year history and say, hey, you're clear. You know, we don't need to require prior auths from you anymore.
Yeah, I agree. Okay, so those are really good suggestions. So Charlie, would you put that on the list of what we would also like the MCOs to report on?
Yes, ma'am.
Okay, so then all we have to do is choose which MCOs we want to report and when. I don't have any particular reason for one over the other. Do we just want to go alphabetically and maybe have 2 report in March and 2 report in, let's see what we got. 1, 2, 3, 4, 5, 6. So 2 report in March, 2 report in May, and 2 report in July.
I think that would be the simplest way to organize it, is alphabetically.
Yeah, I think so too.
Okay. So Charlie, could you get that invitation out to the various MCOs? So I guess it would be Aetna and Anthem in March, and Humana and Passport in May, and United Healthcare and WellCare in July.
Sure, unless you want to do like your tax and reverse that alphabet. I think we've done them in alphabetical order though the last 2 years when they've done them.
Okay, it really doesn't matter to me.
Right. It doesn't.
Okay. I don't know. Let's just keep it alphabetical. So would you send out those invitations, Charlie?
I sure will.
Thank you very much. Let me write it down.
I want to see if Pam will just do a dressing change for me. Okay. He was supposed to be here at 9:30. Yeah, that's what he said. He was supposed to, I talked to him last night.
Somebody needs to mute. Okay, does anybody else have any information that they would like to bring up?
Beth, just as a reminder, or not as a reminder, but just to let you all know, since I am retiring, I'm in the process of switching the Zoom account over from my email to somebody else's, some other account. And what we've done is we created an account that's KY Mac. Let me see if it's Antac, I think. And we're actually going to be using that on the website as well. For people to contact if anybody needs, something prior to the meeting, or if you need assistance when we go back to in-person meetings for the ADA compliance information. But that's one of the reasons why you're not seeing the meeting schedule for the entire year and the Zoom links on the website, is because my fear is that when we switch the Zoom account over, that anything that I scheduled under my account will be messed up when the switch is actually made. So I think they're actually working on that this morning. I've been getting some emails, and I've asked them to wait until after 1 o'clock before they pull any plugs on my current account. But just so you know, that the rest and the tax as well that are here, I'll be getting the rest of those meetings and the Zoom links posted on the website really soon.
Okay, thank you. Well, is that the way we should communicate between meetings? Or will there be a person at DMS, just like you, that we would email through and communicate with?
There will be someone in the transition. I think they're in the process of posting my position now. I don't know that they will get them hired before I leave. So there comes Veronica back on to talk a little bit about that.
Yeah, so I know who to send the agenda to and so forth for the next meeting.
Yeah, absolutely. We will, I'm certain in the next maybe 2 weeks, maybe even sooner, we'll send communication out to the MAC and tax about what the process will be once Charlie retires. And I think that we would want to use the generic email address generally, but then, the person that will be coming on to take over the duties and responsibilities of Charlie, will be somebody that you guys could also communicate with directly.
Okay.
We'll definitely get that out to you soon.
Okay, so we'll just wait then and wait for that communication. Okay. All right, anything else? Okay, well, we can't make a motion, so I guess we will just adjourn. And I thank everybody for attending. It was a good meeting, and I appreciate all the input.
Thank you.
Dr. Parton, and thank you, Charlie, for all you've done.
Thank you all.
Yeah, good luck, Charlie.
Thank you, Charlie.
Thank you.
Keep us posted on that Route 66.
I sure will. I'll let you know, Kathy.
Thank you, Charlie.
Bye-bye.